Welcome to the Campbell University Drug Information Center's educational video shorts. This video utilizes lecture audio from Dr. Riley Bowers and was produced by myself here in the Drug Information Center. This video focuses on heart failure, more specifically classification, staging, as well as monitoring of heart failure. So without further ado, tune in, sit back, and take it away, Dr. Bowers.
All right, classifications of heart failure. This is very, very, very important because if you don't understand this, the rest is going to kind of miss the boat. When we're talking about heart failure, we classify it based on the ejection fraction. So we're talking about the left ventricular ejection fraction. Most of our data from our primary literature and our guidelines centers around HFrEF, heart failure with reduced ejection fraction, HFrEF. HFrEF is defined as an ejection fraction less than or equal to 40%, less than or equal to. You will also see this referred to as systolic heart failure. Systolic heart failure and HFrEF are used synonymously. They shouldn't be, but they are. We have HFpEF, heart failure with preserved ejection fraction, and that is defined as a ejection fraction greater than or equal to 50%. So we've got a little gap in there. We've got a between 40 and 50 that we need to define. There are very few data to tell us what really works well in HFpEF. Then within HFpEF, so in that little range where we don't have good definitions, in the 2013 guidelines, anything between 41 and 49% was considered HFpEF borderline. It's not in the guidelines yet, but this is now starting to be referred to as HFmEF or HFmrEF. That's an ejection fraction 41 to 49%. And the reason that this term is catching on is because there's starting to be more and more data to support different pharmacotherapy options in patients with HFmEF. And then we have HFpEF improved or recovered. So that's just defined as anybody who was at one point in time HFrEF, so reduced ejection fraction of 40 or less, and their ejection fraction is recovered. That should be our goal with all of our patients. So you can get ejection fraction back. Now to further categorize, so we've started by talking about the ejection fraction. Is it HFrEF? Is it HFpEF? Is it HFmEF? Is it HFpEF recovered? We need to know those definitions. Once we get those definitions, we can apply stage and functional class to that. Stage and functional class apply to both HFrEF and HFpEF. We have our stages, our AHA stages of heart failure. That's A, B, C, D. A, we're really not going to see those as heart failure patients because they're just at risk of heart failure. They don't have any structural heart disease or symptoms. They have no structural heart disease or symptoms. Most of our patients that we see, unless we're specialized in critical care cardiology, are going to be in stage B or C. B, we've started to have some structural heart disease, but we don't have symptoms yet of heart failure. You're going to catch this with like an echocardiogram, or some other type of scan. And then C, when you go through the guidelines, stage C is where we have most of our treatment options. So stage C, we have our structural heart disease and prior or current symptoms of heart failure. So as soon as you have that first symptom of heart failure, you go from B to C. D is refractory heart failure requiring specialized interventions, usually mechanical type interventions, not drug therapy, Big key takeaway from the stages is that once you progress, you can't go backwards. So once I'm at C, I can never go back to B. Functional classes, you can move in and out of. So functional classes, you can move either way. As you can see, there are no functional classes associated with A because functional classes are all about symptoms. In stage B, you can really only be functional class 1 where there's no limitation in physical activity. Once we get into stage C, we can move throughout pretty much all of our functional classes. Functional class 1, no limitation in physical activity, and you do not get symptoms of heart failure with ordinary physical activity. Functional class 2 and 3 are where you're going to find most of your patients. Functional class 2 and 3. 2, you have a slight limitation in physical activity. These patients are comfortable at rest, but ordinary physical activity, so like exercise, is going to result in symptoms of heart failure. If they run up the steps, that's going to cause symptoms. So that's going to be functional class 2. Functional class 3, marked limitation in physical activity. They're still going to be comfortable at rest, but pretty much any physical activity is going to cause symptoms. So any ordinary activity, but they're comfortable at rest. Then when we get to 4, they can't do anything without symptoms. Class 4 is going to be your patient that's very short of breath pretty much all the time from their heart failure. In fact, they'll also have symptoms at rest. Monitoring is going to focus around volume status. If we can control someone's volume in heart failure, we can usually control their symptoms very well and keep them out of the hospital. So big emphasis placed on volume status. We're obviously going to monitor their vitals and then presence of any other signs and symptoms. The labs that we're going to check are more going to focus around whichever pharmacotherapy agents that we're using, but we're going to need to keep an eye on our electrolytes at all times. Renal function, because as the heart fails, it's supplying all of your blood to your other vital organs. So when the heart fails, you start losing your other vital organs. Renal failure is very common in heart failure. Sometimes it'll progress to liver failure. We're going to also check our lipids. Our diagnostic criteria, usually the chest x-ray, that's CXR, chest x-ray. It's not our gold standard diagnostic criteria. That's going to be our echocardiogram. So our echocardiogram is actually what's going to give us our ejection fraction. We want to know what that ejection fraction is because that's going to tell us which direction to go with therapy. And then we have our BNP, our brain natriuretic peptide. BNP is a hormone that's released from the ventricles in response to volume expansion and pressure. So as you can see, there's a theme occurring here. A lot of heart failure is about that volume overload. So we got to worry about volume overload. The natriuretic peptides, BNP and ANP, we need to know the differences between BNP and NT-proBNP because you may go to a facility that has the availability to do both. This major difference is that BNP is the active peptide. NT-proBNP is inactive. That's going to become important when we get to Entresto. When we get to the drug therapy Entresto, that will become more important.
We hope you enjoyed this educational video short brought to you by the Campbell University Drug Information Center. We hope you found the information helpful, interesting, and most importantly, that it helped you understand this topic better. We'll see you next time.